Good evening, colleagues. My name is Shahid Chunara, and I'm an orthodontist based in Johannesburg. And tonight we have a very special presentation lined up by Professor Kevin O'Brien. Before we can begin with the introduction of the speaker, here are some basic housekeeping rules. Please refrain from using the raised hand, but type your comments and questions in a Q&A tab. We will have a short Q&A session at the end of the presentation. CPD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile for yourself and access your CPD certificates. Besides that, the event for tonight qualifies for 1 clinical CEU. We are streaming live on YouTube, just in case you have difficulty to access the Zoom platform. So we are just waiting for the numbers to stabilize, and we shall begin shortly. I think, let's have a look at this here. That's perfect. Okay. So tonight, to begin with, I'm truly honored on behalf of the South African Society of Orthodontists and SADA to welcome an absolute giant in the field of orthodontics. Professor Kevin O'Brien has had a long and illustrious career and as both an orthodontist and an academic. His full list of achievements are too many to mention, but certainly impressive. I will therefore attempt to summarize the salient points in his CV, and this was a tough task on its own. Kevin was appointed Professor of Orthodontics at the University of Manchester, aged just 38 years. He has an international research reputation, recognized through numerous research awards, including the Dewey, Salzman, Turpin, and Jerebeck from the American Association of Orthodontics. These are amongst the most prestigious awards presented by the AAO. He has also received numerous other prizes and delivered invited presentations at national and international conferences. He has supervised 10 randomized clinical trials, including the world's first multi-center orthodontic randomized clinical trial. He has over 140 publications in academic journals and 6 contributions to books. He currently writes a blog on orthodontic research, which is read 50,000 times a month. And for those who are not familiar with the blog, I suggest to log on to it and to subscribe to it, because it's certainly a learning experience. He is a past head of the School of Dentistry at the University of Manchester, and a past Associate Dean of the Faculty of Medical and Human Sciences at the same university. In 2019, he retired from the university and has been honored with the title of Emeritus Professor. To just add to that, in this era of self-proclaimed gurus and speakers with vested financial interests, Kevin has been a strong leader promoting evidence-based clinical practice. Through his research and writings, he has consistently challenged both conventional and fringe orthodontics. I personally have had the privilege of attending many of his talks at the AAO in the past. We are truly fortunate to have him here tonight. Without further ado, I'd like to invite Professor Kevin O'Brien to start his presentation. You may share your screen.
Okay, thank you very much. I'll just do that now. Hang on 1 second. I just want to check, can you hear me okay?
Perfectly fine, thank you.
Okay, so first of all, I'd like to thank you for inviting me to talk tonight. I'd normally say I'd like to thank you for inviting me to come and visit South Africa and give this presentation. But of course, times are very different now. I was just trying to remember as you were talking then, as when I did come to visit South Africa, I've got a feeling it was 2004 when I spoke to the South African Orthodontic Conference. It was the same time as the World Cup clinic, the World Cup cricket. So the cricket, I think, was more interesting than my lectures when I saw people sneaking out of the hotel at 12 o'clock. So again, I'd like to thank you for asking me to speak. At the moment, in Manchester, which is in the north of England, we've hit a temperature of 30 degrees, which is just far too hot for us. Anybody who has visited the UK or knows the UK knows that we don't do wet and cold. Sorry, we don't do heat. We do wet and cold. So if I fade as we're going on here, it's just simply that I'm just getting too hot. So what we're going to talk about today really is a sort of a bit of a meander through what we know about orthodontics, snake oil and the orthodontic fringe. In terms of putting our structure together, initially I'm going to talk about this concept of clinical uncertainty, then current knowledge in orthodontics. People say we don't know very much about orthodontics, or we haven't got much of an evidence base. I would say that we have a reasonable evidence base, similar to other specialties and other areas of dentistry. I'm going to then talk one slide on Invisalign, spend some time on myofunctional orthodontics, then discuss snake oil and overall solutions as to how we can perhaps move orthodontics forwards in what is a sort of a very uncertain world at the moment. So let's think a little bit about uncertainty. We as a species have to face uncertainty from year to year, month to month, day to day, minute to minute. We actually do not know what's going to happen with a degree of certainty in the next 2 hours. I think I'm going to give a lecture. We're going to have no problems with it. After the lecture, I'm going to go downstairs and my wife will have been to the chip shop and we'll be eating chips and beer in the garden. That's what I think is going to happen. And I've got a reasonable degree of certainty that that is the case. But our lives are full of uncertainty and we tend not to handle that well. So we also need to remember that uncertainty is present in all our clinical decisions. Everything that we do, no matter even if it's a routine clinical decision, we are uncertain. We can never be 100% certain about whether that decision is correct or not. And an important concept here is that if an operator is 100% certain about everything that they do, then they're probably not a very good healthcare professional, because you can never be 100% certain. But what we try and do with research is to reduce uncertainty. That's the whole basis behind research, is to reduce the amount of uncertainty that we deal with on a daily basis in our clinics. But also it's clear that uncertainty is increased by claims that are based on low levels of evidence. So we've got a dilemma here. We've got research that's been carried out at a high level, decreasing uncertainty, but then uncertainty is sort of paradoxically increased by claims based on low levels of evidence. And we also have to consider, for example, is how much more research is needed. Because we can keep researching the same things forever if we want, but we're not going to reduce that uncertainty very much. So for example, if I take that an example of functional appliances, we know how functional appliances work. I don't want to see another study where someone's banging on about functional appliances slightly altering someone's skeletal pattern. We know how they work. We know, for example, that certain types of bracket are no better than any others, and that the operator has the greatest effect in orthodontic treatment. So we have to bear all this in mind. Because what we're trying to do is practice evidence-based dental care or evidence-based health care. We're no longer the barber surgeons who really relied totally on clinical experience. We are contemporary healthcare professionals. And to do that, we have to practice evidence-based healthcare. Now, I'm just going to quickly nip into this example of the types of research that can reduce uncertainty and help us with evidence-based care. It's a very common description, this. It's called the pyramid of clinical evidence. I'm not going to go through it in much detail because most people will have come across this, but I am just going to draw attention to certain aspects of it. So first of all, the lowest level of evidence that we have in terms of clinical care is the case report. This is where, for example, someone does a treatment, it works particularly well, and they post it up in say in a journal as a single case report. In the days of the internet and Facebook and Instagram and everything like that, people are posting up individual case reports on using social media. While they're interesting, they shouldn't change the way that anybody practices. There's an insignificant amount of evidence that's developed from a case report. The next thing we look at is a case series. That's really where someone's done the same type of treatment and it's worked maybe between 10 and 20 times. Now, they've either struck lucky 10 or 20 times, or alternatively, we've discovered something there, and that there may be some truth to this. There may be reasonable levels of evidence to this. And so that's at a higher level, which is called the case series. Then we have another set of studies, which are case control studies. These tend to be studies where we look backwards at our sort of record collections and sort of analyze those for certain features that may predict the outcome of the treatment that we've just completed. The problem with this type of work is that it's full of selection bias. For example, why have those patients been collected so neatly as a retrospective study? So they do provide us with some evidence, but not a tremendous amount, but we are getting up to the higher levels. So the next level is prospective cohort, which actually has a role within orthodontics. And I would say a lot of dental research. This is where you take a study and you enroll a group of patients and you follow them forwards. Everybody stays in the study regardless of the outcome. And it's a prospective cohort study. These are sort of becoming increasingly interesting and relevant. And so prospective cohort is the next level up. We're now moving to higher levels of evidence, and this is the randomized controlled trial, where patients are randomly allocated to different interventions, and then you measure the effect of that intervention. And of course, I think we're all rapidly becoming very familiar with randomized controlled trials, both in dentistry and in medicine and surgery. We look at the very rapid randomized controlled trials that were done, for example, in the development of the vaccines. Those showed, for COVID, those showed clear effects. And so the randomized controlled trial is a very valuable method of reducing uncertainty about something. And it's the backbone of most high quality medical and dental research. And then finally, right at the top, we've got a systematic review. And the systematic review is where you gather the results of randomized trials, put them together and make an even more powerful level of evidence. So what's the important thing about this pyramid? And I would say the most important thing is I probably wouldn't change my practice looking at any study that's down here. You can sort of draw the line across here to say trials and systematic reviews are going to be what I would really concentrate on and look at very closely in terms of changing or reinforcing my practice. And we need to bear that in mind as I go through here. So it brings us to, again, to this overall concept of evidence-based care. And it's not as simple as saying this should just be clinical trials. I know that when we sort of discovered evidence-based care and randomized trials in orthodontics almost 15, 20 years ago, I probably stood up at a few conferences to say the only thing that's really going to make me change my mind is a randomized trial, and anything else is a complete waste of time. It's not necessarily that case, because you have to consider two other important concepts. And one of those is clinical experience. We have an awful lot of clinical experience as we develop our careers. And clinical experience underpins an awful lot of dentistry. And I think we need to emphasize that that's the case. However, it interfaces with clinical research. And I think one thing that's really important is, if we have clinical experience, which guides us in doing a certain thing, in a certain treatment in one way, and yet clinical research comes in and disagrees with that, then we have no choice but to say, if we interpret that clinical research as being good, that the clinical research outweighs the effect of clinical experience. However, in the absence of clinical research, we may well be leaning very heavily on our clinical experience. Because the other thing that comes in now in more contemporary healthcare is the concept of patient opinion. Patient opinion interfaces with these two main areas, because what we have to do is explain our clinical experience and our clinical research to our patients to allow us to perform or help them take decisions about their care. And that's the proper way that you use you carry out evidence-based clinical care. It's a combination of these three main factors, but I will stress it again. If research is available, that's the main driver of our clinical treatments. So is orthodontics any different from this? And several people have said to me, yeah, that's all very well when you're dealing with things like vaccines or cancer or surgery and important stuff, but is orthodontics important enough to be practiced with an evidence base? I would say it is, quite, for many reasons. I think the most important is that actually malocclusion itself can be a major issue to a large number of children, certainly with the changing social demographic. Patients are getting teased quite considerably about their teeth. Secondly, we want to find the best way of treating people. We don't want to waste their time with lengthy courses of treatment that are ineffective. Neither do we want to be selling them treatments of which there is an absence of an evidence base, because there may be doubts about their efficiency. And secondly, we don't want to be depriving them of their money by taking funds for healthcare for treatment that has no evidence, and there is no real guarantee that it's going to work apart from a few case reports and a bit of advertising and listening to some sort of orthodontic guru. So it is very important that we do this in orthodontics. So while we've got to that point, what I'm going to do is, so what do we really know about orthodontics? What can I say has a reasonable evidence base within orthodontic treatment? Well, I think first of all, looking at contemporary factors, is first of all, no method of speeding up orthodontic treatment works. You hear all sorts about pills and potions and vibratory devices and special magic brackets and things like that. The important thing is no method of speeding up treatment works. Trials have recently been done showing that most treatment actually is influenced by the operator. And you would think that would be true, because the operator probably has a greater effect on treatment than any type of appliance, bands or brackets. So that does bring me to say is the bracket and the wire don't really matter. It's what the operator does with the bracket and the wire. And it's the individual skill of the operator that influences treatment outcome more than the brackets and the wires. It's easy to straighten teeth. Anyone can stick some brackets on in the right place, straighten the front 6 teeth, and they think the job's done. It's not necessarily correct. Certainly there are times that we compromise, but frequently a lot of treatment is more complex than just lining the teeth up. We cannot change skeletal growth. There is not a single study that has been done in orthodontics that shows that we can change the way a child's face is going to grow. There is absolutely nothing. We get little changes, we get small degrees in A and B and other cephalometric measurements, but actually they don't add up to much. And there's been the most amazing amount of research that has done into this area, because it's something that we all would really like to do, but we cannot change anyone's skeletal growth. It doesn't happen, full stop. What else do we know? Extraction of teeth is sometimes necessary. Most of the time, I think I would always like to treat patients without extractions, but actually sometimes extractions are necessary. If your treatment mechanics are correct and you know what you're doing as an orthodontist, those extractions do not cause any harm at all. There is absolutely no evidence, for example, that the extraction of teeth has any influence on the airway, despite what some people say. And I know there's a gathering momentum on this, but I would like to see one piece of research that shows me that the extraction of teeth damages the airway. Now, the mechanics that you use as an orthodontist or anybody straightening someone's teeth may dish someone's face in, but that's probably a fault of the mechanics rather than the extraction of the teeth. We should generally maintain the arch form. You can't widen arches to the levels that people are claiming. The risk of relapse is too great, and the risk of putting the teeth through the alveolar bone is also too great. We don't know much about relapse. That's the area that people should be looking to now in orthodontic treatment, is we actually don't know much about relapse. That's the bottom line. We don't know why teeth relapse. We know we have to retain them. We can't prevent relapse. There's no publication that I ever seen that has convinced me that we can prevent relapse, no matter what type of appliance we are using. And then the operator effects, as I said earlier, outweigh all the other things that I've just discussed. So let's just move a little bit into an area that was once controversial. And this is that concept of early screening and early treatment. Now, early treatment it ebbs and flows within orthodontics. At the moment, we're in a phase where we're becoming more interested in early treatment, because I think there isn't anybody who wouldn't want to do a treatment that would intercept the development of malocclusion. I think there isn't anyone who wouldn't want to do a treatment that would make a later treatment easier. And it is that concept of we should, you're reading about this all the time, saying that we should be screening children at 7 or 8 to intercept malocclusion. That's why you do screening. You do screening to intercept the progress or the development of a disease. But to carry out that sort of screening and interception, you actually need to show that an intervention is effective. And while there are some interventions that are effective, such as the removal of primary canines to allow permanent canines to erupt, early correction of crossbites, etc., there's not as many as we would hope to see. And I think that's very important, that we need to look at that. Again, if I was starting my career, I would be looking very strongly at early treatment and carrying out trials of early treatment, because it's still an orthodontic holy grail. However, we have done some work into the early intervention of the development of class 2 malocclusion, and it was work that was done by 3 main centres. One of these was in, 2 of these were in the United States. One was in Florida, in Gainesville. One was in North Carolina at Chapel Hill, and one was a study that I ran in Manchester. All the studies ran pretty much about the same time. We tended to follow each other. Ours was the 3rd study into this area. We all used the same methodology, and we learned from each other's mistakes. So the question that we tried to answer in our studies was, could we intercept the development of class 2 problems by providing treatment early, for example, when the children were 8 to 10 years old in the transitional dentition? You can't do much more with our sort of conventional appliances at that point. These studies were done in the 1990s, and we were tending to use functional appliances that at least were anchored to the teeth or fitted most of the teeth. And or is it better to wait until someone is an adolescent and correct their problem in sort of one short-ish 2-year treatment, again using functional appliances and fixed appliances? So our question really is when is the best time to provide functional appliance treatment to children with class 2 problems? Is it early, when they're younger, or do we wait until they're an adolescent? Because at that time, people were going on really about the benefits of early treatment. And these sort of claims are still being made about all sorts of other treatments. And I think that the claims that people are making, they should perhaps look, it's always useful, I think, in orthodontics, and certainly any other specialty or area of dentistry, is just look back and see what's been done before, learn from our history, rather than trying to make new claims, which perhaps have been answered previously. So one of the issues is that early treatment gives us more orthopedic change. There's less need to dentally compensate for a class 2 problem. It leads to that magical goal of reduction in extractions, because we'd all like not to extract teeth. It reduces the length of any treatment time during adolescence. A compelling reason, and completely logical, isn't it? If you reduced a child's overjet at 8, surely that overjet is going to stay reduced, and you're not going to have to do that again when someone is an adolescent. And you're going to get a better occlusal result because everything works in a very lovely way. And then finally, another claim that's being made recently is that by early interception, you're actually increasing the airway and the children end up with a great airway. So let's have a look at some of this. So this was a patient I treated in the trial that we did, and we randomly allocated children when they were aged 8 to receive treatment straight away, or to be put into a control group where they didn't get any treatment, and we treated them when they were when the permanent dentition established at 11 or 12. You know, they got delayed treatment, and that was the more conventional treatment. So this was someone that I treated in the early phase of the study. She was randomly allocated, again, no choice from me. She was randomly allocated to receive treatment. She got treatment with a mixed dentition twin block appliance. This was her pretty much at the end of that first phase of treatment, sort of 12 months later. And you can see that her overjet has been reduced. I've got space everywhere. If I believed in skeletal change, I'd say the appliance had changed her skeletal pattern from here to here. But in fact, I think this was just a stroke of luck. We have to remember that children grow. Some of them grow well and some of them don't. And then this was her at the end of all orthodontic treatment, again, when she was 16 or so. So that's my miracle result. This is the picture I'd be plastering all over Facebook if I believed I changed skeletal patterns and things like that. But this is just an example of someone who had treatment in our studies. So why does that evidence matter? Well, first of all, we need to be careful. We need to make sure we're not making incorrect claims for treatment. We're not to be making claims for the incorrect timing of treatment. And we've got that overall dilemma, or we had it, of early versus late treatment. And then another concept, which I think was very important, I think it's still important now, is if we're not going to change someone's skeletal pattern, why don't we just wait until they're 12 to, until they're 14, and then start them on orthognathic surgery, where we can move and change their skeletal bases with a degree of confidence. You look at the picture of that girl. Would I have treated her with a functional appliance now? I think I probably would, because I'd like to see what I could get. I also wouldn't want to leave someone with very prominent incisors until they were 14 or so. But I might have started getting them ready for that concept of having orthognathic surgery. But I'd have to do that very carefully. So it brings us to, what did we find then about someone who turns up like this saying, what are we going to do about her? Well, this was the paper we wrote. It's now a classic paper. It's been quoted hundreds of times now. It certainly has changed orthodontic treatment, along with the papers that were written by the Florida and the North Carolina groups, because we all came to the same conclusion. So the dilemma was, what do we do? Treat early or treat when adolescent? We've combined the results of these studies into a Cochrane review. Remember I said that systematic reviews were an important method of doing this. And so we've combined them through into a systematic review, which was published about 2 to 3 years ago and now needs updating, because there are other studies I think that would help increase our sort of level of evidence here. if anybody wants to know about this and they don't want to look at the systematic review, these are shameless plugs for my blog. Just have a look at my blog pages, type class 2 malocclusion, and you get everything delivered in sort of blog style. And then we've got the trials, and then we've got the individual systematic reviews. So what did we find? We really found not very much, to be honest, in terms of the evidence, sorry, in terms of anything that would suggest that early treatment is effective. So these are data from the systematic review, and this is looking at the difference at the end of the day between the patients who had orthodontic treatment when they were 8 and then had another course when they were older, or the group of patients who just had one course of orthodontic treatment where they were 12 or 13. And there is no difference at all between any of those outcomes that we measured here for this group of patients. So it led us to conclude that for most effects, there was no advantage in carrying out treatment early. In fact, what happened was treatment early took longer, was more expensive, and if anything, burnt up cooperation, which we needed in that important older adolescent phase of treatment. However, there was one thing that came out, and it was quite important, and that was the fact we looked at incisal trauma. And the paper that we wrote was published in the American Journal of Orthodontics, and we had some quite interesting conclusions. So this is a table of the risk of trauma. So the patients that had to wait until they were adolescent, they had a 31% risk of trauma. For those who had early treatment, they had a 19% risk of trauma. So actually, by treating someone early, you got a 12% reduction in trauma. And I think that was a clinically relevant measure. The important thing that we need to look at when you're looking at this concept of relative risk reduction, which really is the risk of events, and the important concept here is that there is a risk in both groups, so you've got to look at relative risk, is early treatment reduced the risk of trauma by 33%. Quite a compelling finding. So what do we know about early treatment? So we can say to our patients, we can treat early and intercept your malocclusion, or attempt to intercept your malocclusion. We will correct your overjet. We will fix your prominent teeth for a while, though you have to accept that they might relapse while we're waiting until you get older. There is a reduction in trauma. There is a transient improvement in self-esteem, which was interesting, but it washed out, that difference washed out when the children were older. So it was perhaps a boost that they got when they were about 10. And there's actually no differences in the final outcome between starting earlier or later. The major difference was that the cost of treatment was considerably more if you started early than later. Your potential benefits were a probability of a reduction in trauma. Harms, though, are important. We can treat early. The overall treatment time was increased. It was pretty much added to by 18 months. The cost will be greater, both to you and the healthcare system, and opportunity cost. And the occlusal result may not be as good as simple one-phase treatment. That's the information we have. So we can conclude, I think, from that first part of my lecture here, that functional appliances work. They reduce overjets. That's what happens. They have some skeletal effect, but most of it is dentoalveolar. And I still say, no matter what type of appliance that is supposed to correct class 2 malocclusion, you're always going to have a dental effect, which is greater than any skeletal effect. These functional appliances, no matter how we dress them up, tip teeth. That's what they do. So the movement is mostly dental. So that takes me just to that first bit. I've been asked to talk a little bit about Invisalign. I'm not going to talk very much about Invisalign because I've never been an Invisalign operator. I've always treated children at a children's hospital, of children who were sort of chronically ill or had various craniofacial syndromes and problems. And Invisalign didn't really come into our armamentarium. I've looked at the research on orthodontics and on Invisalign, and another reason I'm not going to talk about Invisalign very much is that there is a remarkable lack of research about this type of treatment. However, I can't help thinking, and I still do think, that this is a great development. It really was revolutionary when they introduced Invisalign, and the use of clear aligners has revolutionized and it's changed orthodontics. But what do we know about it? Well, first of all, it's primarily adult treatment. We are starting to see so-called interceptive stuff with Invisalign at the moment. And I don't think the results from that, and they're just case reports and case series, are looking very good. And I certainly think I could probably do better with sectional fixed appliances or even simple removable appliances. But that's perhaps my skill as an operator, being a sort of a more traditional orthodontist who used fixed appliances for nearly everything that I did. But there is also a complete absence of any high-level evidence about the effectiveness of Invisalign. But it is effective for the right case. But we don't know what the right case is because there's no research being done on it. So we're really governed by our clinical experience. And that's where it gets a little bit dodgy if we start making claims that, for example, that we can use Invisalign to treat adolescents, because there's no evidence that it's any more effective than fixed appliances, and in fact could be less effective than fixed appliances, which means we're not acting ethically. So that does lead us to teen, and Invisalign teen is really a leap in the dark as far as I can see at the moment in terms of orthodontic research. So moving now to myofunctional treatment. This is interesting. I actually find this very interesting. So myofunctional treatment is where you take a preformed appliance to fit the patient's mouth. These are rather like a modified sort of positioner. There's nothing new with this stuff. We might be using different types of plastics, but it's been around for an awful long time. So it's a combination of using these appliances along with myofunctional exercises in an attempt to sort of change the oral environment. And by changing that oral environment, you may be providing orthodontic treatment that perhaps does more than traditional fixed appliances. That's the theory. I'll go back and say we need to look at history. So, for example, practicing in Europe, the Germanic and the sort of Eastern European countries used to lean, and they still do to a degree, quite heavily on myofunctional exercises for children. And so it's not new. It's not a new revolutionary treatment, this. It's sort of a rejig of an old one. If I was very cynical, I'd say a myofunctional appliance looks like what we would call a positioner, or even a fancy sort of activator appliance. Again, nothing new. But the main advantage as I see it, which I think is compelling to me, if I had stronger levels of evidence, is that if you can just take an appliance out of a box, fit it into a child with no impressions and no lab fee, and it works, then you can sign me up for that, because I certainly would be using it. So most of this at the moment is being delivered by using a Myo brace, which, as I say, is nothing particularly new. Even the Myo brace company say that they have been treating malocclusion for over 25 years. Well, actually, people have been doing myofunctional appliances for nearly 100 years. But it is interesting, as I say, this is a very interesting concept. Claims that are made is that you can intercept the development of malocclusion, just as I discussed there with class 2 treatments. It enhances skeletal growth, it increases the airway, and it alters muscle function. The holy grails of orthodontic treatment. Every new product I see, and I've been around a while now, goes on wanting to increase the airway or enhance skeletal growth and reduce treatment time. As I say, I'm getting quite sort of cynical about this now. It just seems to be every now and then someone comes up with this new stuff, makes claims, makes a bit of money, and then they all disappear. And it's happened since the dawn of orthodontics. But they're preformed appliances, and that's really interesting. So you know, I've done a little bit of work on myofunctional stuff. So I've sort of been on their website, and again, they've got case reports and they show things such as this. Now, what we need to remember is what is normal dental development when we look at these pictures. So again, I'm looking at this and thinking, yeah, that malocclusion has been corrected. I don't think I would ever say she had severe spacing, because to me, that's not severe spacing, and that's not an extreme overbite. That open bite, that actually to me is a thumbsucker's open bite. And you can fix that with anything. You can use a 2x4 appliance, you can use a Hawley, a Roberts retractor, you can use a functional appliances, and you can use a myofunctional appliance. And that's what this appliance has done. It's not done anything that's magic. It's tipped those upper incisors back. As you tip the upper incisors back, the open bite goes down. It probably coincides with the child who's stopped sucking their thumb, and your treatment is done. You could have just stopped them sucking their thumb, for example, and that problem would have resolved quite naturally. But it doesn't hurt to put an appliance in for a quick blast of treatment. Here's another one there. They said this child had an undeveloped upper and lower jaws with a deep bite. It's common and it's often left untreated. So they treated that 5 minutes with a Myo brace. I could have done exactly the same sort of thing, nothing special, with fixed appliances, bite planes, functional appliances. Said facial development was improved. There's no pictures to show that. Oh, and this is quite a nice one. So this is a 12-year-old male patient with a severe crossbite at the start of treatment. I'm not so sure he's 12 actually when I look at these pictures, but putting that aside. So he found it difficult to chew. Using the Myo brace over 3 years, he's avoided the need for braces and even extractions, but that crossbite's not been corrected. The lateral incisor hasn't been picked up. So I don't understand how this treatment can be claimed to be successful. I would say it's a sort of a compromise treatment as it stands at the moment. And again, I could have done that with all sorts of fixed appliances and expanders, got exactly the same result, nothing special. I actually think if I'd just done that with a simple expansion plate or a quad helix, it would have taken me far less than 3 years. Here's another one where all they've done is put the overjet up. You can see that these incisors have been proclined to accommodate everything else. They've swapped one malocclusion to another for another. This is another one that I saw that I picked up on Facebook, showing that the treatment was quite remarkable. Yeah, it is remarkable because nothing much has happened from there to there. The incisors have uprighted a bit, but the overjet's the same, pretty much the same. So it's remarkable that someone thinks that there has been a change there. So that's a cynical viewpoint on the advertising that we're seeing. What have we got in terms of evidence? Well, as things stand at the moment, we've got 2 trials that were published, and they were pretty good trials, to be honest. And they tended to compare the Myo brace versus activators, or a Myo brace versus an untreated control. The one that interested me the most was probably the Myo brace versus the untreated control, though that hasn't published its long-term results yet. They did show, interestingly, the studies that were carried out in Scandinavia into the Myo brace versus an activator appliance as a trial, is that there was a high discontinuation rate with both appliances of just over 60%. That, you know, I would say if I've got a brace, if I'm using appliances where I've got a discontinuation rate of 60%, I shouldn't be using those appliances. Discontinuation rate of twin blocks, for example, in younger children are 18%, and in older children it's about 28%, and that's fairly consistent. The overall conclusion there was that there was no difference really in the Myo brace and an activator, but importantly, the Myo brace costed less to the healthcare system, and it cost considerably less because you didn't have to pay for the functional appliance to be made. And to me, that's again, I go back to it, that's a pretty amazing selling point, is you can just take an appliance out of a drawer and it works. Unfortunately, it only works, or it doesn't work 63% of the time. And that means I wouldn't use that appliance. So I've blogged about this quite a lot. People have been surprised about the degree of open-mindedness that I've got about myofunctional orthodontics, but I've also challenged myofunctional research considerably and got into some right ding-dongs on their Facebook page. In fact, I was banned for a while for asking questions that were a little bit too difficult for them to answer. So what do I think? I think there may be something to this treatment. I can't dismiss it. I can dismiss the claims that are made because these claims are made for a lot of new orthodontic appliances and for a lot of treatments that actually, with the passage of time and trials, have been shown that they don't work. So there might be something to this treatment. And I think a lot of orthodontists think, yeah, there could be, but we want to see some research. If there was evidence that it was highly effective, I would use it. It would have been brilliant for my caseload of children at the Children's Hospital if I could just take an appliance out of a packet and fit it into a child's mouth without impressions. So if there was evidence, I would use it. But there's no evidence. There's a complete absence of evidence on the effectiveness of these appliances. And what we're finding is that people are starting to use them. They're charging the patients quite a lot of money, or the patients and their parents quite a lot of money to use these appliances, and yet they don't seem to be any more effective than the appliances that we've got at the moment. Now, I work within a socialised healthcare system, and this is where I start to feel strongly about things. And I know it's different in South Africa, but certainly when I hear of people being charged £7,000 for some sort of myofunctional appliance, when they could have got similar treatment, giving them a similar result for free on the National Health Service with any other functional appliance, that sort of makes me a bit cross, because that's where people are moving towards fraud. So it is an issue, and it is quite important, and there's limited research, and I don't think I could ethically use these appliances as things stand at the moment. So I've got 3 questions. Why doesn't the myofunctional research company do some research? They don't. They consistently refuse to do research. They've got enough money to be able to get some research done, but like many orthodontic inventions by companies, they turn a blind eye to carrying out some research. Why do dentists use this in the absence of evidence? And I think they're sort of flying for the sales pitch. There's a lot of conflicts of interest around. I'm sort of very aware that in most countries in the world, there's a sort of someone who is called a bit of a pioneer, but actually they might be a paid consultant to myofunctional research. So of course, they've got a vested interest in promoting these appliances. Their Facebook groups are very active. And I think that does persuade dentists that they should be doing this type of treatment because it's being sold as quite easy. And I actually think it's, in the absence of any training or any real proper experience, and also selling this appliance and its overall philosophy to patients, I think that is unethical. And can patients consent in the absence of evidence? Just think about it. If you're saying we're going to fit this appliance and it's going to improve your child's facial profile and it's going to improve your airway, your child's airway, there's no evidence that you can do that. So can someone consent in the absence of evidence? And I would say they wouldn't. One of the things you missed out is I used to be chair of the UK General Dental Council, and we drove quite hard on evidence behind all types of orthodontic treatment. And certainly there are some practitioners that have lost their license for making claims about the effects of various appliances for temporomandibular joint problems and facial growth that weren't supported by any evidence because they were not providing informed consent to the patients. You could provide informed consent by saying, I've got this appliance, it comes out of the drawer, and we don't actually know what it's going to do because we've got no evidence to support it, but it's going to cost you £5,000. Moving on now to the sleepy child and obstructive sleep apnea, another big area. Again, within my blog, this has been looked at. The main points, it was looked at in a lot of detail by the American Association of Orthodontics, who carried out a very extensive research project into obstructive sleep apnea and breathing problems in children and orthodontics. And they concluded that obstructive sleep apnea is serious. There's no evidence that dental or skeletal factors cause obstructive sleep apnea. One of the greatest causes of obstructive sleep apnea is obesity. Dentists and orthodontists cannot diagnose obstructive sleep apnea. It can only be done by a physician. Two-dimensional, three-dimensional imaging is not diagnostic. You can't diagnose obstructive sleep apnea from images. And orthodontics doesn't help in obstructive sleep apnea. There is absolutely no evidence that any type of orthodontic treatment can influence, can either cause or cure obstructive sleep apnea. So our overall summary there of their white paper was that orthodontists and dentists cannot predict, prevent, diagnose or cure sleep apnea. So we've got this orthodontic nirvana that I try and inhabit. And that is that we're going to have trials into everything and we're going to be able to underpin with evidence. And when there is an absence of evidence, it's got to go on clinical experience, but at least people need to be honest about their clinical experience, particularly with consent, because that sort of brings us to snake oil. So what I'm going to now look at is orthodontic quackery, which is quackery really is something that we're having to deal with, and that is the promotion of unsubstantiated methods that lack a scientifically plausible rationale. You've got to have some science behind anything that you're going to promote. So the way that things work for orthodontic quackery is, first of all, the person who is selling the appliance or the treatment, they recommend against conventional therapies. So they will say that conventional orthodontic treatment causes breathing problems, extractions cause breathing problems. They promote potentially harmful therapies. What harm can you do with orthodontic appliances? Well, going into protracted treatments that are ineffective, you could cause root resorption. You could burn up cooperation, which means a later course of orthodontic treatment perhaps isn't going to work. They tend to promote magical thinking, which is also quite important. There's always a little bit of mysticism about this alternative treatment. And you drain patients' bank accounts because none of this is free and sometimes it's occasionally quite expensive. So I wrote a blog about this saying I decided to become an orthodontic quack and a snake oil salesman. And I developed a quackery checklist. So the first thing you need to do is develop a new disease. You can call this new disease whatever you like. The latest one actually is orthodontic induced sleep apnea. You develop a new method of diagnosis. So there's all sorts of cephalometric analyses that are done. Our newest method of diagnosis, of course, is cone beam images of the airway, which of course have been shown to be ridiculously inaccurate. We think up a new name for treatment. In the UK, we have orthotropics. That's our sort of new name for a treatment that people provide. You set up courses for dentists, and your target is always dentists. It doesn't tend to be orthodontists. The target for a lot of these courses is dentists. And you criticize others. You unleash a torrent of criticism against what people regard as conventional orthodontic treatment. I think that's a little unfair. I've criticized conventional orthodontic treatment most of my career, but it's always been underpinned by science, not just personal feelings about a new appliance or new treatment that I've developed. And then you resist debate and dismiss research evidence. There's a complete dismissal of wanting to carry out research and also to do research. So what is orthodontic quackery? These are the ones that are going on at the moment. One is expansion all the time, expanding maxillas as if there was no tomorrow. The other one is orthotropics and myofunctional. And I'm putting my orthotropics and myofunctional in here, even though I think there might be something to them. But I want someone to do the research. Self-ligated brackets, the claims that were made there, none of those have been supported. So anyone who is pushing self-ligating brackets is an orthodontic quack as far as I'm concerned. Orthodontic airway physicians, there's no influence on the airway, and methods to speed up orthodontics don't work. I'm just going to nip through this next section because it's not rapidly important. So why does this approach work? And I think we need to think about this. So I read 2 books. Occasionally I will read a book that isn't a Jack Reacher book. And so these are 2 books that I read when I was laid up a while ago, which is the classic book by Daniel Kahneman and Thinking Fast and Slow, and also Helga Novotny's book, The Cunning of Uncertainty. And these were quite interesting because Kahneman argues that humans struggle to think statistically. We don't like probability, we don't like chance. And our understanding tends to be based on a small set of observations. You know, for example, I always worry about missing a flight because I missed a flight once. I think I'm going to miss every flight I take because I missed one once. We don't like chance. We don't handle it very well. And we assume that a past event will predict a future event. So if we had a good result with any type of appliance, we assume we're going to get that again when we use it. Helga Novotny points out that we have an aversion to loss. We have an aversion to failure. We don't tolerate uncertainty very well, sort of building on that theme that I discussed earlier. But the problem with science is that uncertainties are couched in precise terms. And you know, we just need to look at any of the scientific literature and you see that people are never 100% certain. So our science is that uncertainties are couched in, they're sort of couched in precise terms. They're completely upfront. I mean, the biggest example for this is what's going on in the UK at the moment, where our government has decided we're going to give the COVID virus a complete free-for-all just to see what happens. They don't know what's happening, neither do the scientists, and we're getting loads of stuff now where they're saying we actually don't know what's going to happen. So looking at orthodontics here, this is me writing about trauma. And you see that I said here, I talked about incisal trauma, and I've said, how certain are we of this data? The confidence intervals are very wide, so there's a degree of uncertainty in the data. Lyle Johnson, who is a sort of a guru of academic orthodontics, sort of says, if you use a functional appliances, you'll pick about 1/10 of a millimetre of growth a month. On some patients more, and on some patients less. However, you won't be able to predict which patients will respond better. He's uncertain. Though we look at other things, this is full face orthodontics, Derek Mahoney out of Australia. We can treat as early as 6 or 7. The benefit is we're working with growth, we're making space. Age is the most important factor that separates the new approach to orthodontics. He's very certain about it. John Mew, intervention at an early age prevents the development of problems. He doesn't say might prevent, it's interesting. Treats the causes, not the symptoms. Makes the face fit the teeth. Very definite phrases. Mike Mew, John's son, says it's very strange. He's making a very clear and obvious message. Unfortunately, these claims are dismissed, usually with nonsensical comments such as a lack of evidence. Again, resisting debate, resisting scientific research, because scientists don't tell people what they like to hear, and that's a problem. So what are we going to do about this? There are several solutions. First of all, general practitioners. Any dentist can provide orthodontic treatment throughout the world, and there's nothing wrong with that as a concept. But dental schools don't teach students to be competent in orthodontic treatment. And I know we don't do that because I used to run a dental school and I've taught dental students since 1986. So we've got an orthodontic black hole in terms of knowledge. And dentists are getting interested in orthodontic treatment. And why shouldn't they do it? But they've got this black hole, and that tends to be exploited. Specialists, I sometimes wonder if they've lost their skills of critical appraisal, to be honest. They tend to believe the bracket salesman for some reason. but we need research, and they actually perhaps need more research in the orthodontic specialty programs and more research in the undergraduate programs. So our solutions: the dental schools should revisit the curriculum. Specialist societies, I think, should be much more proactive using websites, blogs, Twitter and Facebook. There isn't a single orthodontic society in the world that has a good internet and website presence for lay people, and they're just not good at it. And I think that's a major deficiency of the specialist societies at the moment. And I think we need to promote evidence and counteract some of the sort of the key opinion leaders and the orthodontic fringe who are sort of exploiting our degrees of uncertainty and vulnerability about treatments that might have a role, but our evidence is lacking. So that's pretty much all I've got to say. As we were sort of said earlier, if you want to read anything about this, it's all on my blog, which is a completely free blog. I have a co-author now with Prof Fleming, who's a professor of orthodontics in London. Neither of us make any money out of this blog. It's all completely free access because we believe knowledge should be free. So that's pretty much all I've got to say. I've gone over, well, I've come in on an hour, which is what I was asked to, but I'd really hoped to speak for about 50 minutes. But I think it's time we sort of switched over to the Q&A session.
Thank you very much for this very enlightening talk, Kevin. Judging by the viewer response and a number of questions, it certainly got people thinking and people talking. And thank you for your very nice, concise manner in which you've discussed everything. I'm going back to the Q&As now. There's been some good questions that have come through. And just to start with them, I know that you've touched on this before, but one of our attendees has asked, is there an orthodontic solution for the treatment of sleep apnea in adults?
No. I'll not be so cynical about it. Some orthodontists, and I know some of them very well, use mandibular advancement appliances as an alternative to CPAP, because CPAP is a pain. Yes. And those appliances do work. But what they do is they hold the mandible forwards, and that sort of frees up the airway simply because they're moving the soft tissue envelope forwards. But what happens when you stop the appliance? The mandible goes back when they're asleep, and the problem still arises. There hasn't been a trial on this as far as I've found, but there has been sort of reasonable cohort studies on bimaxillary advancement in orthognathic surgery, bringing the midface forwards. And that's the only work that's been done. Conventional orthodontic treatment, I can't see how that would influence sleep apnea in adults. Just logically and physically, I don't see how it would work.
I think that's a standpoint of the AAO white paper on sleep apnea as well. That was a seminal document at the moment from all the research. Yeah. Perfect. Okay, and there was another question which asks, isn't the issue of relapse common sense?
No, not really. I think people have tried to avoid relapse using different orthodontic philosophies. And if we do think about them, there was a philosophy that where you tried to, for example, leave the lower incisors where they were, thinking that the lower incisors would sort of operate in that functional zone. But that doesn't seem to make much difference. I mean, the actual research on relapse, as I said earlier, it is disappointing because most of it has been sort of retrospective research looking back, which means that you have to have biases in there. I don't know how I would do research on relapse, to be honest. I don't think I could randomly allocate people to different types of orthodontic treatment unless I was convinced in my mind that I was in equipoise and that they were all going to relapse, for example. They are all going to relapse. I mean, this is something that people do miss out on, is that actually most orthodontic treatment relapses as the face grows with the change in muscle function that we have as we grow older. We all know that our faces aren't the same as they were when they were 12 or 13. In fact, a lot of our body isn't the same as when we were 12 or 13. You know, we start to go downhill from 17 or 18. So maybe irregular incisors and irregular teeth actually are part of the aging process. And we just either have to accept it as part of the aging process, or we have orthodontics again and long-term retainers. It is the same, it's the same dilemma, I think. I actually think relapse is part of aging, and we can't stop time.
Yeah, perhaps I'd like to contextualize that question, because I think there's been some murmurings from some of the companies that says that if you alter the envelope and they go back to Enlau's principles and they talk about growing bone, and which we know and you've spoken about it hasn't been proven, but they think that you will reduce relapse if you start the kids off at younger ages by developing the dentition so that your tooth is in an ideal position. I think that's been one of the arguments from some of the companies to say that that relapse can be controlled and can be prevented if you had the skeletal base and the tissues around them working in unison with the dentition. Any evidence on that?
I mean, that is the holy grail, isn't it? And we've been trying to change skeletal patterns really since the invention of orthodontics. We must, you know, it doesn't hurt to go back, and going back, you're looking at Angle's work. You know, the person who invented orthodontic treatment, he expanded all the time because he thought he was making bone grow. He misinterpreted Wolff's law. And so he thought he was making bone grow, and what happened was nothing much. A lot of his cases relapsed that were then retreated according to legend. But the theory's fine. Let's make faces grow. But I've not seen one bit of research that says this type of appliance can make a face grow any more than it would do from its genetic blueprint. That's the issue. And so you can't make that claim that you're going to make a face grow because you don't know with adequate uncertainty.
Thank you for that. There's been a question here. What do you make of headgear utilization then? Where I went to dental school, headgear was heavily utilized. In fact, Dr. McNamara was one of my instructors, and I participated in a Moyers conference after all these years. I'm feeling thoroughly confused. Secondly, have you ever encountered a dental philosophy of cuspid extraction? So there's two questions, there's two parts of the question. What do you make of headgear utilization? And and secondly,
headgear,
the philosophy of cuspid extraction.
I mean, headgear was the mainstay of American orthodontics. It was used extensively. And it's only now really with the development of temporary anchorage devices and various other implanted distalizers that headgear use is dropping. Headgear still only, when you look at the research, the effect of headgear on skeletal pattern is absolutely minimal. Again, most of its use is dental alveolar. And that's what you're getting now with the new appliances. So I think, and also there's risks involved with headgear and there's cooperation issues. So in terms of headgear utilization, it is stopping. I don't know a single orthodontist that uses headgear any longer. Most people have moved towards using implants of various types. So yeah, it moved teeth. It moved teeth very well. It didn't move bones. And I think that's the important concept. A dental philosophy of cuspid extraction. No, I've never sort of come across that at all. I'm sort of looking at it thinking, what does that really mean? No, unless canines are very displaced, I wouldn't extract them. So I don't think there's a philosophy of that.
Perfect. Just going down some of the questions, and as I said, we've got quite a few that just have been answered by your lecture already, and so I'm not going to go into those. And I think that there's a question that's a bit specific over here, and it says, what's your opinion on the Damon Q2 system in relation to interceptive corrections for crowding, vertical and horizontal discrepancies? cross bites without extractions. I know you've touched on this, that no magic appliance exists, and self-ligating appliances have been proven not to do any magic that a conventional bracket doesn't do. But this is a specific question, and they're trying to use the Damon Q2 system in specific instigations like interceptive corrections in lieu of expansion, I presume.
Yeah, and again, I think that self-negating brackets and Damon brackets, we sort of used them, I used them for a while because it was something new. Everyone was using Damon brackets, so I felt a bit left out in our department, so I used Damon for a while. They're a nice bracket until you want to start to torque the teeth, and then you found there wasn't enough torque, and I was taking the brackets off and putting on my conventional straight wire brackets. They're nice. You think they're nice and clean. You can click the clicky thing in and out all the time, getting archwise in and out very quickly. They're a bracket, and all the research has actually showed that they have no advantages over any other type of bracket. So, and certainly in expansion, yeah, you can expand with anything. It's not the brackets that expand the teeth, it's the arch wires. So if you make your arch wires wide, your brackets are going to move the teeth. So it's the wires, not the brackets, that make things wide.
Yeah, we had similar research done at the University of Pretoria. One of my postgrad students did research via my practice, and we had found the same thing. The wires were the biggest factor, the brackets made little difference. There's an interesting question here. What do I do with example, a 4-year-old child with an obvious class 2? Do I leave until the child is much older, when ready for treatment, according to hand X-ray?
Well, it depends. So if you've got a young child, they're permanent inside. Certainly, I wouldn't treat them at 4. No chance. There's no point in doing that. So I would be looking to say, right, will I be treating that child in the future? The answer to that is probably yes. Should I wait until their incisors have started to erupt? Because I might be worried about trauma. I also might be worried about teasing. And so then what I would do is I would give the child and their parent the information that we've got from the class 2 studies, which says you're going to get a lot of orthodontic treatment to sort this out. It's going to cost you double the time because you're having treatment now. Your benefits are not going to be that great. But if you are worried and you're concerned about suffering trauma, and certainly with a large overjet I might just give them a blast of twin block appliance treatment just to get that overjet down to a reasonable level. We found in our study that using twin blocks in the transitional dentition, it was really quick. And actually we were reducing quite reasonable overjets in about 6 months. The problem was they didn't stay. That was the issue. And a lot of people needed to continue treatment later. So I probably would intercept with a severe overjet. And by a severe overjet, I'm thinking anything that's above 8 or 8 and upwards. I'd be looking at a blast of interceptive treatment, but I wouldn't make any of the claims that people are making. I'd say, I'm just going to get your front teeth back. We'll do it as quickly as we can. Let's see how that goes.
Yeah, I suppose the stigma attached to having such a severe overjet and a risk of more than some intervention. Yeah.
And that's what the trials tell us.
Yeah.
We're practicing evidence-based care.
Perfect. There's a very broad question. I don't know if you want to tackle this, but it says, what are your basic rules for retaining teeth position?
Really, it is one of those things that people go for sort of lifetime retention or push quite hard on lifetime retention. There's no such thing as lifetime retention because no matter what your retainer is, it will break. So I actually would always tell my patients to wear their retainers for as long as they want, as long as they feel they can. At some point in their life, they'll stop wearing their retainers or they'll break. If they're bonded retainers, they could have them repaired. If they're Essex retainers, which is becoming increasingly popular, they could be replaced. But then they have to think is, do they want to wear retainers forever? My children all had orthodontic treatment, and the girls my daughter's retainers are just little bits of bent and broken wire on the inside of their teeth, and they want me to remove them. But since I've retired, of course, I'm not allowed to do that. So it is. So I often leave it as a patient's choice, but I also tell them that relapse is potentially inevitable, and you need to consider if it's part of the aging process that you could put up with. You know, a lot changes about us as we grow older, not just our teeth, and so it depends what they can tolerate. That's the way I do. I leave it to them. A lot of the time, I give evidence to patients and say, this is what you know, the research evidence says. You decide.
Perfect.
That's the way I look at it.
Makes sense. Yeah, I think there's essentially here there's been a lot of compliments in terms of your presentation, so thank you for that. And here's a question here. If a child has habits like thumb sucking and tongue thrust from the age of 3 or 4, should we wait to place a habit reminder like a tongue gate? And when a child presents with an orthodontic need, when would the best time be to refer a patient to an orthodontist? Could you perhaps give a general answer? So there's two
again, this depends on your healthcare system. So in the UK, you can refer early, but it has to be very specific problems, such as large overjets, crossbites, and things like that. So what you should be doing is looking to see, well, what can be corrected now, realistically, or what is going to harm that child's dental health. And again, I would go to canines, impacted canines, crossbites, large overjets, and things such as that. Maybe developing class 3 problems that an orthodontist might want to consider using a reverse headgear on, because we know that those work as well. You know, they work quite nicely. So, but the other time is also ring your local orthodontist, talk to the orthodontist and say, when do you want to see people? And then I don't know if it's the same in South Africa, but in the UK, there's a little bit of a barrier between orthodontists and general practitioners. They don't do enough talking to each other, and no one picks the phone up and says, what do you think about this? And so that's the way I would look at it. If a child's got a thumb sucking and they're persistent at 3 or 4, I wouldn't worry too much, because we're only dealing with primary teeth. But actually, I'd like to break that habit. And so I probably would place some sort of, simple removable appliance plate will break the habit. You'd also can talk to them a lot about stopping sucking their thumb. You don't need to fit an appliance to stop them. Most children will stop anyway. But if I was really pushed, I might just fit a simple removable plate, because that'll stop them.
The position standpoint from the South African Society of Orthodontists is very similar to the AAO standpoint, that we want to usually see patients before the age of 7, not necessarily to do work, but rather to map the road ahead. So that's what we would usually say is a good time to start looking at things. But as I said, it depends on a case and all the rest of it. I think with that in those, I think that's about it in terms of the questions that you haven't covered.
Do you want me to pick a few?
Please go ahead. Yeah.
I'll just take a couple of minutes. So someone's asked me the question of the double-blind study on the 2 parachutes, the famous paper, which you don't need to do a trial on whether parachutes work. Of course you don't. And it's a sort of example that people often use who are opposed to trials. What I would say is, what would I rather have? Would I rather have treatment that's been trialed for its effectiveness, or something that someone has got no evidence? I mean, we're all getting vaccines in our arms at the moment. As a little bit of an aside, I've been working as a vaccinator for the past sort of 6 months. No one has ever asked me, is this vaccine going to work? Because we know it works because of the trials that have been done. So it's obvious you do need to do trials, but there's certain things that you actually don't need a trial. And that is jumping out of an airplane with or without a parachute.
That's facetious.
Okay, someone said, I'm not comparing apples with apples. The Maya brace is not an activator. Could I please fact check? It's a type of activator. I'm not going to go for that at all. It's a type of activator. You might dress it up as all sorts of phrases. It's probably a cross between an activator and a flanker. They all do the same thing. It's simple. There's nothing special about it. It's not magical. It's not a super appliance. It's an activator. And no one can convince me that it's not an activator. Maybe someone from my embrace would actually try and explain to me why it's not an activator, but it's not an activator. Doing the same thing wrong for years is also called experience. Yes, it is. There are plenty of people who sell their clinical experience, work on their clinical experience doing the wrong thing, and occasionally they end up in front of the regulators and occasionally they don't. Someone says, why don't we take some of the £7 million and do independent research? I don't know what that means. Someone has said that Barry Raphael and German Ramirez, I've corresponded with these two, and they're doing research and producing evidence-based results. I've not seen anything at all, and I'd love to see it. If they, and again, I'm going to throw the challenge out to the anonymous attendee who's posting here. Give me the evidence. Show it me. Show it
very
me.
vehemently backing the my functional appliance, the anonymous attendee.
Yeah. Just show it me. MRC has shown historical evidence and saying Edward Angle on the integrative approach to orthodontics. No, they haven't, because they've not shown any decent evidence. Let me just, I'm just going to look at a couple one. I can't find anything else that is an obvious that I need to just knock back. What courses can a general dentist do to be able to be equipped to orthodontically treat patients? Those are interesting. We've moved in the UK, which is an interesting concept, that there are courses set up for general dentists, but they're set up by specialist orthodontists. And what they do is they use the advantages of the internet and digital scanning and everything like that. And dentists will present their cases to the orthodontist, and the company will also, and they will sort of look and say, yes, you can treat this one. It's a fairly straightforward one, and this is the way we would do it. And then the dentist periodically sends scans back to the specialists, and they discuss it online. They also have weekends away and things like that. And that actually seems to work quite nicely. The thing about orthodontics, and we all forget this, is some of it is dead easy. You know, a non-extraction class 1 lineup is dead easy. A general practitioner can do that. What general practitioners lack, because of the lack of training in dental schools, is they lack the ability to spot a case that's within their competencies. And that's what a specialist does. The specialist looks at a case and says, right, that's an easy one, that's a difficult one, that's a really difficult one. And that's where general practitioners run into trouble, where they work outside their competence. So the way that these courses run, and I'm a big supporter of them, is that they build a practitioner's competence by giving them advice over a 5 to 10 year period, and it works. And it works very nicely. And there's several of these companies in the UK. And they do well.
So to come in there was a question asked, why aren't dental schools worldwide introducing general practitioners to fix orthodontic appliances? Can you answer that question?
Sorry, I've just seen a question. I've just seen a comment, and I'm going to read it out. Sorry, what did you say?
I saw that. Okay, so the question was, okay, taking on from your answer right now, why is it that dental schools the world over have not, most mainstream dental schools have not introduced fixed appliance therapy to general practitioners during the undergraduate training?
There's not time to get it into the curriculum. It's as simple as that. You haven't got the patience and you haven't got the time within the curriculum. Yeah. The curriculum's overcrowded. And we faced this dilemma in the UK. And what we decided to do was to give practitioners, and I think it's the same all over the world, is that a newly qualified dentist knows when to recognize malocclusion, they know how to talk to patients about orthodontics, and they know when to refer. And I think that's the most important thing.
I'd like to wrap up with one final question here. What is your opinion on treating mouth breathing early to influence growth?
Can you treat mouth breathing? That's the first question. Can you effectively treat mouth breathing? And does mouth breathing resolve with natural facial growth anyway? That's another important concept. I don't think there's anything wrong with trying to do it, but you have to have that with all sorts of caveats to say that you're not 100% certain that it's going to be effective. It's not, treating mouth breathing is not going to influence facial growth. Mouth breathing doesn't influence facial growth. People quote Harvard studies on the monkeys that had their facial growth influenced by completely blocking their noses. Well, yeah, of course your facial growth is going to be influenced because you've got great big lumps of acrylic stuck up your nose and you can't breathe through your nose. That's going to do all sorts of things. So yeah, there's nothing wrong with giving it a shot, but don't promise that you're going to influence someone's facial growth. Don't charge them a fortune for some super myofunctional treatment that you can't guarantee is going to work. I've lost the great question. It was the best comment that's ever been made to me since in my entire career.
Wow.
And it was something about the fact that I was managing to talk bullshit so confidently. They're amazed that anybody believes it.
I think he's deleted it. So that he's retracted his statement.
The only person that makes that comment on a regular basis to me is my wife, and I've known her for 33 years. And she does say to me, I'm not at work now.
you can at university, but at home you just Kevin.
I'm going to go for one more question because this person.
Yeah, please go. Please go.
Why do I use twin block appliances at all if I don't believe that it affects growth? I do use twin blocks because they move teeth. They're great for moving teeth. You can reduce overjets, you can correct developing cross bites at the back, you can correct molar relationships with twin blocks. There's tons of research that shows that, but it doesn't influence growth. That's what I was talking about earlier on. If there's one big headline message here, it's no orthodontic treatment influences facial growth with a degree of certainty. There is a complete absence of evidence. If you tell your patients that you're going to influence their facial growth with your appliance, you are acting unethically. Bottom line. I think that's a good place to stop, isn't it?
That's a fantastic place to stop. Thank you so much for being such a good speaker, for being so helpful and humble to answer all these questions and overstay your time because we were meant to have finished a long time ago. But
I'm sorry.
Questions. Judging from a number of questions, you certainly got our people thinking. And on this, the coldest night in Johannesburg tonight for the whole year, to get people to sit out here and listen to you, that's a feat on its own. So thank you for that. We really thank you for a wonderful lecture, and we hope to host you again in future. And that's all I can say. Thank you so much.
Okay. Thank you very much. I'll go and get my chips and Peroni. Thanks very much, and thanks everybody for listening. And
enjoy your heat.
And take care out there. It's dangerous.
Thank you so much.
Okay. See you soon. Bye-bye.
Bye.
Thank you, gentlemen. We will end the session now. Good night.